Through the front, Jeremy, let's see it.
Yeah, hold the tomatoes for the end, right? So, thanks, Matt, for giving me this talk, and it's a pleasure to be here. Good to see you, brother. So, these are my disclosures. There's a pertinent one that I do work with Stryker. You'll see some implants. The most pertinent disclosures, I still do posterior hip revisions. My practice is about 50-50 anterior posterior in terms of my approach. So don't hate me just because of this talk. So when do I consider DA for revisions? Actually, these are some generalizations. It's actually good for the acetabular revisions. And for me, that's becoming my approach of choice for that, regardless of their primary approach. And then on the femoral side, early periprosthetic fractures, if they had a DA approach, infections after DA, and surprisingly, total femurs is where we've migrated. These are some of our acetabular revisions where I think it can give you power to get inferior fixation that I think is unmatched when you've got fluoroscopy and some of those tools. But we're talking about the femoral side here. So can we do this safely? Well, this is out of Columbia. This is a series of several of their DA revisions at midterm follow-up showing about 90% survivorship. So I think it's reasonable with the sort of the standard smattering of complications. What about changing approaches? Discordance bad? Well, this is out of 3 academic centers, and basically found discordance of revision approach had no impact on dislocation, infection, or fracture. So you can choose a different approach safely, but you should be doing that based on good reasoning. And then does the approach really drive dislocation, as we see in primaries where we think that the anterior-based approaches may have a slightly different or lower dislocation rate? Well, in the revision setting, this is out of Joe Moskow's group, no difference in dislocation rates by revision approach. And so I would say don't choose this just for stability. It should be an approach that you know how to do and that is well advised for a certain patient. So how do we do it? So I think it's all about knowing how to extend the incision and knowing what's there and what not to get into. Approximately, it's pretty easy. You extend the incision, kind of